So this 59-year-old gentleman had a road traffic accident, and it was managed conservatively for a while, about 3 months. Then he presented to one of the hospitals in the city where he had a primary total hip replacement. There was no foot drop. He was being put on a protected weight bearing for about 3 months. There was no infection. However, with the time, you can see at 7 weeks and 10 months, and also there was some doubtful history of a fall, which how much it is contributed, we can't tell. Patient ended up with this kind of situation in our OPD after around 11 months after the operation. So how do you proceed with?
Who in the panel wants to take it on? Yeah, Dhanashekhar, yeah.
So to rule out a pelvic discontinuity first, so I'll need a
Can you go back to the old X-rays?
Judith views, and probably the fracture is not healed and introp stability was not achieved, so it is gone inside. So I'll reconstruct the posterior column with a plate and use a larger jumbo cup and get an introp stability.
So that CT is before surgery, yeah? That CT that is short. Can you just show the CT again, please?
Yes, there are investigations done. If you see, that's when he was presented to us, and we have some CT here as well. I'll go with the next one. If this is the CT we did, 3-dimensional, when the patient was with this complication to us. You can see the anterior column is still intact, whereas the posterior column has a break and also the protrusion of the cup with 3 screws. As a continuation of the previous discussion, in this case, do you do angiogram?
No, the CT will already show the proximity of vessel to the screw. You don't need to do a separate angiogram.
Yeah.
They can identify the vessel, the closure. Yeah.
So we have an angiogram, which was done preoperatively in this patient because the screws were out. And also it was reported as there is some amount of, that one of the screw is very near some branch of the superior gluteal vessel. So we had asked the vascular surgeons to be on standby, and as planned, this is what we did. CT angiogram, we had some allograft ready. We thought of doing a posterior column fixation and revision cup with peripheral screws superiorly and inferiorly. You might have noticed the stem position was also changed from first X-ray to the last X-ray. Even the stem has come out a little along with the cup migrating inwards. So we thought whether you should do a plating only or use something like a cage for the posterior column to bridge the posterior column and wall, and obviously the bone graft. So I took him to OT, removed all the previous implant. The femur came out very easily because it was already come out a little bit. And one of the broken screws we couldn't catch, and we left it alone. Did a posterior column plate, and then put the cup in this position after putting the graft, which you can see in the next picture better. And we also thought of putting some medial mesh to have, you see, contain the graft, but because of the big graft we could use on the medial side, we didn't have to use a mesh. So the posterior column fixation, a couple of big femoral head, and we got the femoral side also changed. This is a close-up view. You can see the bone graft which has been impacted medially. We have 3 screws proximally, 1 screw inferiorly. There are peripheral screws as well. This is a peripheral screw which allows with, is allowed in this stem. That is 6 months. You can see the consolidation of the bone graft becoming stronger and stronger with the time. And that's at 9 months. And that's when we saw him day before yesterday. We called him to get his video, very latest one. We love ROC. And that's the latest picture. The similar another patient, the message is here: if you have a acetabular fracture of any kind, the stability is very, very important, which we have discussed earlier before we get into the total hip replacement. In this case, you can see a columnar screw, anterior column, which is holding the column, and then the THR, similar one. The column is first fixed, stabilized before you do a primary THR if you are going to do. So the lessons learned are like acetabular fractures, stability is important, or go straight forward, secondary THA later on, which is more safer, less complicated. Plating with bone graft has been used in this case. Restoring center of rotation is quite important. Otherwise, the offset, leg length, dislocations are high. Thank you very much.
So Vijay, any patient who has a fracture like this kind of fracture primarily, and they operated so early for a total of like 4 months, which is quite an earlier time for that whole thing to get consolidated. So you don't get a good socket or malunited place. So it should be minimum of 9 months to 12 months before somebody interfere, or you have a proper inventory to do it, rather than doing just the primary hip like this.
That's correct. Some of these patients are very disabled, so you cannot wait for 9 months. But having said that, the very first X-ray that you showed was not evaluated properly. So when you have a posterior column discontinuity, no cup can hold, no matter how many screws that you put. So you have to establish that, and then you need to restore the posterior column with a plate before you put the cup. So all these principles cannot be violated. The other point is that when you have a screw and the CT angiogram shows it's near, there is no need to immediately do something from the medial side. You can have a vascular surgeon on standby and still go, likely that nothing will happen. But if something happens, you have vascular, no, you don't have to do something, extra peritoneal, intrapelvic, you don't have to do anything like that. And then anterior column is more forgiving than posterior column as regards component stability, but you need to get some fixation before you put your socket inside. And if you are not experienced, do not rush into post-accidental fracture surgery. The longer you wait, it will be advantage.
Yep.
So a lot of patients, we think that with this instability, that instability, within 3-4 months, everything glues up, and then you have a very straightforward thing to do a THR. So that's the message from this case. Thanks very much.
And if you can see on the other side of the hip, this patient has a lot of staples inside his pelvis. This is a very elderly renal transplant patient. There's no way we could fix the pelvis and come back for another operation. That's why we planned for a primary THR.
Fixing the pelvis is one thing, but especially condition like this, you can just wait for some time.
Yep.
And then that will still glue up. That's still, of course, obviously malunited, but great to do a THR on. So that's the other thing. Yeah, then Shekhar?
I have to treat the osteoporosis. I always put them on teriparatide for 3 to 6 months.
Absolutely. As Rajesh, Professor Malhotra was saying, you need to metabolically optimize all patients, not only these patients, for whenever you do arthroplasty. Yeah.
The fracture pattern in acetabulum that is more prone for non-union and not uniting at this period is the transverse fracture pattern. Most other patterns heal up. Transverse fractures of the acetabulum are prone for non-union. So those are the ones that do not unite by 3 to 6 months. So
absolutely, yeah. So those may need some kind of fixation first before just waiting for nature to heal it up. And very good point, yeah.
And also this fixation need not be nicely reduced. It's only to produce the stability.
Absolutely, yeah.
Patient like this, you mentioned there is a fracture and we cannot operate for 3-4 months and we put them on teriparatide. Right now they won't be load bearing, right? So will a patient which is not load bearing because of pain in the hip will have better bone quality just because of teriparatide? Does it happen that way? I don't know.
No, teriparatide I think even helps even if you don't, it's better to have weight of course for bone remodeling, but if you don't, even teriparatide works even without. That's why bedridden patients get significantly well after teriparatide.
It's not necessary to load the joint. If you are sitting up, there is enough force acting on the hip.
The muscle force generated itself is enough, yeah.
That loads the hip.
I will say I have seen several cases though of terapeptide treatment where they've got significant HO.
Right, okay. So that's a point, yeah. So everything there's a negative side to that. Potentially can cause more HO if you use any kind of thing that interferes with bone metabolism. Okay, thanks.